The radiology report disappears into her purse at 2:47 p.m. Not casually, not absent-mindedly. I watch Mrs. Ellen Hartwell fold the paper in half, then in half again, and slide it deep into her leather bag with the kind of deliberate secrecy that makes my stomach clench. "Mrs. Hartwell," I say carefully, "we need to discuss those results with your husband. The mass we found on his CT scan?" "No." Her voice is quiet but absolute. "David's not ready for this. He's been through enough." I'm standing in the consultation room at Hospital St. Halsted, 6 months into my internal medicine residency, and I've just delivered news that changes everything. David Hartwell, 68 years old, came to the emergency department this morning with abdominal pain. The CT scan I ordered shows a large mass in his pancreas, almost certainly cancer, though we'll need a biopsy to confirm. His wife asked to speak with me privately before I talked to him about the results. I'd assumed she wanted to prepare herself emotionally, to ask questions without him present so she could be strong for him later. I hadn't expected her to hide the report and refuse to let me tell him. "Mrs. Hartwell, I understand this is frightening, but your husband has a right to know about his own medical condition. He needs to understand what we're dealing with so he can make informed decisions about treatment." She looks at me with eyes that have seen too much, weathered too many storms. "Dr. Reyes, you don't know my husband. You don't know what he's been through. This information will destroy him, and I won't allow that. With respect, that's not your decision to make. Patient autonomy is a medical term." She cuts me off, her voice sharp now. "Made up by doctors who've never had to watch someone they love fall apart. David is my husband of 42 years. I know what he can and cannot handle, and he cannot handle this." The report is in her bag. The diagnosis is hidden. And her husband is sitting in an examination room down the hall, waiting for me to tell him why his stomach hurts. What happens next will force me to navigate one of medicine's most complex ethical dilemmas, the collision between a patient's right to know and a family's desperate desire to protect. What Mrs. Hartwell knows about her husband, what she's been hiding for months, will challenge everything I thought I understood about truth, autonomy, and the complicated love that exists between people who've spent a lifetime together. My name is Dr. Noah Reyes, and I'm 27 years old, which means I'm young enough that some patients look at me with skepticism and old enough to understand why they should. I'm a first-year internal medicine resident at St. Halsted Hospital in a mid-sized American city where autumn is just beginning to paint the trees in shades of rust and gold. The hospital was built in 1924, a brick monument to early 20th century optimism about medical progress, with modern additions grafted on over the decades like architectural afterthoughts. I grew up in Houston, Texas, the son of Mexican immigrants who worked crushing hours so I could have opportunities they'd never dreamed of. My mother cleaned houses until her knees gave out. My father drove trucks across state lines, sometimes gone for weeks, his spine permanently curved from years of lifting and loading. When I got my acceptance to medical school, my mother cried and lit candles at church for a week. My father gripped my shoulders and said in Spanish, "Ahora puedes ayudar a la gente de la manera que nosotros nunca pudimos." Now you can help people the way we never could. Every patient I see carries that weight. Every decision I make echoes with their sacrifices. The thing they don't tell you in medical school is how much of medicine happens in the gray spaces between what's medically correct and what's humanly complicated. The textbooks teach you pathophysiology, pharmacology, clinical algorithms, but they don't teach you what to do when a wife hides her husband's cancer diagnosis, when families disagree about care, when patients make choices you know will harm them, when the right medical answer conflicts with the human reality in front of you. My attending physician, Dr. Marcus Webb, has been trying to teach me to navigate these gray spaces. He's 52 years old, with silver hair and wire-rimmed glasses, and he has this way of asking questions that force you to think beyond the algorithm, to consider not just what you can do, but what you should do. Last week, we'd been discussing a patient who refused treatment for his diabetes because he believed his condition was punishment from God and accepting medication would be rejecting divine will. "What do you do, Noah?" Dr. Webb had asked. "Explain the medical consequences of untreated diabetes. Try to understand his religious beliefs and see if there's common ground." Good start. But here's the deeper question. Whose life is it? If he's fully informed about the risks and consequences, and he still chooses to refuse treatment based on his deeply held beliefs, do we have the right to override that choice? But we know he's wrong. Diabetes isn't divine punishment, and treatment isn't rejecting God. We know that from a medical and scientific perspective. But knowledge isn't universal, Noah. Belief systems are powerful, sometimes more powerful than medical evidence. Our job isn't to force our worldview on patients. It's to inform them, support them, and respect their autonomy even when we disagree with their choices. That conversation had stayed with me, shifting how I thought about patient care. Medicine wasn't just about fixing bodies. It was about understanding people, their contexts, their beliefs, their fears. Today started routinely enough. I'd arrived at 6 a.m. for morning rounds, reviewing overnight admissions and checking on patients from previous days. Around 9 a.m., the emergency department had paged me about a new consult. 68-year-old male with epigastric pain, asking for an internal medicine evaluation. I'd headed down to the ED and found David Hartwell in Bay 6, a tall man with thinning gray hair and kind eyes, sitting on the examination bed with one hand pressed against his upper abdomen. His wife Ellen sat in the chair beside him, an elegant woman in her mid-60s with carefully styled white hair and worried eyes. "Mr. Hartwell, I'm Dr. Reyes from Internal Medicine. Tell me what brought you in today." His voice was steady but strained with discomfort. "Pain in my stomach. Started about 6 hours ago. Right here." He indicated the upper middle portion of his abdomen. "Sharp at first, now more of a constant ache. It's been getting worse. Any nausea or vomiting?" "Some nausea. No vomiting yet. Changes in your bowel movements? Blood in your stool?" "No blood. Maybe some looser stools the past few weeks, but I thought that was just something I ate." I'd taken a detailed history. David was a retired accountant, generally healthy except for well-controlled hypertension, no previous surgeries, no family history of cancer or significant GI disease, non-smoker, occasional alcohol. He'd been feeling fine until a few weeks ago when he noticed some vague abdominal discomfort and fatigue that he'd attributed to age and stress. "Stress about what?" I'd asked. He'd glanced at his wife before answering. "Our son. He's been going through a difficult time. Divorce. Lost his job. It's been weighing on us." Ellen had reached over and squeezed his hand, a gesture so automatic it spoke of decades of comfort given and received. I'd performed a physical examination. David's abdomen was tender in the epigastric region, but there was no guarding or rebound, no signs of acute surgical emergency. His vital signs were stable. He looked uncomfortable but not critically ill. "Mr. Hartwell, I'd like to order some tests, blood work to check your liver and pancreas function, and a CT scan of your abdomen to get a better look at what might be causing this pain." "Is that necessary?" Ellen had asked quickly. "Couldn't it just be an ulcer or something he ate?" "It could be," I'd acknowledged. "But given the location and quality of the pain, I want to rule out more serious causes. The CT scan will give us detailed images and help us make an accurate diagnosis." David had nodded. "Whatever you think is best, doctor." The blood work had come back concerning. Elevated liver enzymes, elevated bilirubin, elevated amylase and lipase, suggesting pancreatic involvement. And the CT scan, when it came through 2 hours later, showed exactly what I'd feared. A large, irregular mass in the head of the pancreas, 4 centimeters, encasing the superior mesenteric artery, compressing the common bile duct, with several small lesions in the liver that looked suspicious for metastases. I'd stared at the images on the computer screen, my stomach sinking. Pancreatic cancer. Almost certainly pancreatic cancer. One of the most aggressive, difficult-to-treat malignancies we encounter, and based on the size and location, likely already advanced. I'd printed the radiology report and gone to find Ellen, who'd asked if she could speak with me before I talked to David about the results, which is how I ended up in this consultation room, watching her hide the report in her purse and refuse to let me tell her husband that he probably has cancer. "Mrs. Hartwell," I say, trying to keep my voice calm and professional despite my rising concern, "I understand you want to protect your husband, but he needs to know what we've found. This isn't something we can keep from him." She sits very straight in her chair, her hands folded in her lap, her expression controlled, but her eyes betraying deep fear. "You said it's probably cancer. You said you need a biopsy to confirm, so you don't know for certain yet. The imaging is highly suggestive. Suggestive, not definitive. So there's still a chance it could be something else. Technically, she's right. Without tissue diagnosis, we can't be 100% certain. But the CT findings, the irregular mass, the vascular involvement, the liver lesions, paint a clear picture. The radiologist's report uses phrases like highly concerning for malignancy and recommend urgent biopsy and oncology consultation. Mrs. Hartwell, the chance that this is anything other than cancer is very small. Your husband needs to know so we can move forward with the biopsy and start making treatment decisions. Treatment decisions. She says the words like they taste bitter. You mean chemotherapy, radiation, surgery that probably won't work, months of suffering for maybe a few extra months of life. And we won't know what treatment options are available until we have a definitive diagnosis and staging. I've done research, Dr. Reyes. Her voice is steady, but I can hear the tremor underneath. Pancreatic cancer. 5-year survival rate of less than 10%. Most patients die within a year of diagnosis. The treatments are brutal and rarely extend life significantly. Am I wrong? She's not wrong. Pancreatic cancer has one of the worst prognoses of any malignancy. It's usually diagnosed late because early symptoms are vague and nonspecific. By the time patients develop noticeable symptoms, the cancer is often already advanced. The statistics are sobering, I admit, but every patient is different, and new treatments are being developed all the time. Mr. Hartwell deserves the chance to make informed decisions about his own care. He deserves to have peace in whatever time he has left. Ellen's composure is cracking now, emotion breaking through. David has severe anxiety, Dr. Reyes. Diagnosed 20 years ago. He's on medication for it, but it's not fully controlled. When he's stressed, he spirals. He can't eat, can't sleep. His mind goes to the darkest places. 3 years ago, when our daughter was in a car accident, she was fine, just minor injuries, but David fell apart. He was hospitalized for a week with what they called acute stress reaction. He couldn't function. I'm beginning to understand her fear. Mrs. Hartwell, I appreciate you sharing that history, but anxiety is manageable. We can involve psychiatry, adjust his medications, provide support. You don't understand. She leans forward, intensity in her eyes. 2 years ago, David's best friend Jim was diagnosed with colon cancer, stage 3, treatable, good prognosis. Jim started chemotherapy, and David watched him go through it. The nausea, the exhaustion, the loss of dignity. It terrified David. He made me promise, made me swear, that if he ever got cancer, I wouldn't let them put him through that. He said he'd rather die quickly than suffer through treatment. This is new information, and it changes the ethical landscape considerably. Did he put that in writing? Does he have an advance directive specifying his wishes? No, it was just a conversation. Late at night, after visiting Jim in the hospital, David was upset, not thinking clearly, but he meant it. I know he meant it. Then we need to ask him again. Now, when he's calm and informed. His wishes from 2 years ago, said in the context of watching a friend suffer, may not reflect what he'd actually want now when facing his own diagnosis. Ellen shakes her head firmly. If you tell him, he'll panic. He won't be able to think rationally. He'll agree to anything just to make the fear stop. And then later, when he's going through treatment and suffering, he'll realize it's not what he wanted, but it'll be too late. Or, I counter gently, if we don't tell him, we're taking away his right to make decisions about his own body and life. That's not protection, Mrs. Hartwell. That's control. The word lands hard. She flinches as if I've struck her. I'm not trying to control him, she says, her voice breaking. I'm trying to protect him from suffering that won't help him. Can't you see the difference? I see a wife who loves her husband and is terrified of losing him, I say, softening my tone. But Mrs. Hartwell, withholding a diagnosis from a patient is ethically and legally problematic. Patient autonomy, the right of people to make informed decisions about their own health care, is one of the fundamental principles of medical ethics. Medical ethics? She says it dismissively. What about human ethics? What about the ethics of forcing terrible knowledge on someone who can't handle it? What about the ethics of taking away someone's peace in their final days? Before I can respond, there's a knock on the consultation room door. Dr. Webb enters, his expression neutral, but his eyes alert. He's clearly been paged about the situation. Mrs. Hartwell, I'm Dr. Webb. Dr. Reyes is attending physician. I understand there's some concern about how to proceed with your husband's care. Ellen straightens, composing herself. I'm requesting, that you not tell my husband about the mass you found. Not yet. Not until we know for certain what it is. Dr. Webb pulls up a chair and sits down, creating a triangle of conversation. Tell me about your husband. Help me understand why you're concerned about sharing this information with him. And Ellen does. She tells him about David's anxiety disorder, about his hospitalization 3 years ago, about his reaction to his friend's cancer diagnosis. She tells him about their son's recent divorce and job loss, about the stress David's been under. She tells him about 42 years of marriage, about knowing her husband's breaking points, about the promise she made that she'd protect him. Dr. Webb listens without interrupting, his face thoughtful. When she finishes, he's quiet for a moment. Mrs. Hartwell, I can hear how much you love your husband, and I understand your fear that this diagnosis will overwhelm him. But I need to be clear about something. We cannot withhold a diagnosis from a patient who has decision-making capacity. Your husband is alert, oriented, able to understand information and make choices. That means he has the right to know about his medical condition, even if that information destroys him, even then. Because the alternative, making decisions for him without his knowledge or consent, violates his fundamental rights as a person and a patient. Ellen's face crumples. So you're going to tell him. You're going to walk into that room and tell him he has cancer and there's nothing I can do to stop you. We're going to tell him that we found something concerning on his CT scan that needs further investigation, Dr. Webb says carefully. We'll present the information honestly but sensitively. We'll assess his understanding and his wishes, and we'll involve psychiatry if needed to help him process the information. And if he falls apart, if this pushes him into a crisis, then we'll support him through it. But Mrs. Hartwell, not telling him isn't a long-term solution. Eventually, he'll notice symptoms worsening. Eventually, he'll need treatment or hospice. Eventually, the truth will come out. Better to have that conversation now, when we can provide support and information, than to have it forced on him later in a crisis. I watch Ellen process this, see the resignation settling over her features. She reaches into her purse and pulls out the folded radiology report, placing it on the table between us. I knew you'd say that, she says quietly. I knew I couldn't stop you, but I had to try. I had to do everything I could to protect him, even if it was futile. Dr. Webb picks up the report but doesn't unfold it. Mrs. Hartwell, may I ask you something? This promise you made to David about not putting him through cancer treatment, do you think he'd want you to hide his diagnosis from him? She's quiet for a long moment. No, she finally admits. He'd want to know. He'd be angry if he found out I knew and didn't tell him. But wanting to know and being able to handle knowing, those are different things. They are, Dr. Webb acknowledges. Which is why we're going to approach this carefully. Dr. Reyes and I will talk to your husband together. We'll present the findings, explain what we know and what we don't know yet, and discuss next steps. You can be present if you'd like, or you can wait outside if that's easier for you. I'll be there, Ellen says immediately. If he's going to hear this, I need to be there. Dr. Webb nods. Before we go in, is there anything else we should know about your husband? Anything that would help us communicate with him effectively? Ellen thinks carefully. David values directness. He doesn't like things sugar-coated or talked around. If you're going to tell him clearly. Don't dance around it with medical jargon and euphemisms. He'll respect you more for being straightforward. That's helpful. Thank you. Dr. Webb stands. Are you ready? Ellen takes a deep breath, squaring her shoulders like someone preparing for battle. No, but let's do it anyway. David Hartwell is sitting on the examination bed in Bay 6, flipping through a magazine without really reading it. He looks up when we enter, and I see anxiety flicker across his face. The instinctive response people have when a doctor walks in with serious expression and another doctor in tow. David, this is Dr. Webb, I introduce. He's my attending physician. We've reviewed your CT scan results and we'd like to discuss them with you. It's bad, isn't it? David says immediately, looking between us. Ellen's been in there a long time. You wouldn't have brought in the senior doctor if it was good news. Dr. Webb pulls up a rolling stool and sits at eye level with David. A deliberate choice to make this conversation feel less hierarchical, more human. We did find something concerning on your scan that we need to tell you about. David's hand reaches out automatically, and Ellen moves to his side, taking it in both of hers. Just tell me, he says. Whatever it is, just tell me directly. I appreciate that he's asking for exactly what Ellen told us he'd want. Mr. Hartwell, the CT scan shows a mass in your pancreas. It's about 4 centimeters, roughly the size of a golf ball. Based on its appearance and location, we're concerned it could be cancerous, though we'd need a biopsy to confirm that diagnosis. The words land like physical blows. David's face goes pale. His grip on Ellen's hand tightens. For several seconds, he doesn't speak, just sits there processing what I've just said. Pancreatic cancer, he finally says, his voice hollow. That's one of the worst ones, isn't it? It's a serious diagnosis, Dr. Webb confirms, but we don't have a confirmed diagnosis yet. The next step would be to perform a biopsy, take a small tissue sample from the mass so we can examine it under a microscope and determine exactly what we're dealing with. And if it is cancer, what then? This is the conversation I've been dreading. Because the honest answer is difficult. and David has specifically asked us not to sugarcoat things. Treatment would depend on the stage and extent of the disease, I explain. Options could include surgery, chemotherapy, radiation, or a combination. The oncology team would need to evaluate you and discuss the specifics. What are the survival rates? David asks bluntly. I want to know what I'm looking at. Dr. Webb and I exchange glances. This is the moment where we have to balance honesty with hope, truth with compassion. Overall, 5-year survival for pancreatic cancer is around 9 to 10%, Dr. Webb says carefully. But those are just statistics, Mr. Hartwell. They don't account for individual factors. Your age, your overall health, the specific characteristics of the cancer, new treatments that are being developed. Every patient is different. David nods slowly, and I can see him retreating inward, processing the information. His breathing has become shallow and rapid, signs of mounting anxiety. David, Ellen says softly, remember what Dr. Williams taught you. Breathe slowly, in through your nose, out through your mouth. He follows her guidance, taking deliberate breaths. After a moment, some color returns to his face. I need to think, he says. It's a lot. I need time to process this. Of course, Dr. Webb says. Take whatever time you need. We're not making any decisions today except what immediate testing to do. No decisions, David repeats. Then he looks at Ellen with an expression I can't quite read. Part fear, part something else. You knew, didn't you? Before they came in here. They told you first. Ellen's face confirms it before her words do. Yes, I asked to hear the results first so I could prepare myself. To protect me, David says, and there's an edge to his voice now. That's what you were doing, right? Deciding whether to tell me or not. The air in the room shifts, tension crackling between husband and wife. David, I was scared, Ellen admits. I know how you get when you're stressed. I was trying to figure out the best way to handle this. The best way to handle it is to tell me the truth. His voice rises, anxiety giving way to anger. I'm the one with the mass in my pancreas. I'm the one who has to make decisions about my own body. You don't get to decide for me what I can and can't know. I wasn't deciding for you. Yes, you were. You were in that room with the doctors, hearing my test results, and you were thinking about whether to hide it from me. Admit it. Ellen's eyes fill with tears. I was thinking about protecting you from information that I knew would devastate you. Is that so wrong? Yes. David's hands are shaking now. Whether from anger or anxiety, I can't tell. Yes, it's wrong, Ellen. We've been married for 42 years. And you know what's held us together? Honesty, trust. Even when things were hard, even when we were struggling, we told each other the truth. And now when it matters most, you want to lie to me? I didn't lie. Withholding information is the same as lying. Dr. Webb intervenes gently. Mr. and Mrs. Hartwell, I think we need to take a step back. This is an extremely stressful situation, and it's natural for emotions to run high. But we're all on the same team here. We all want what's best for you, Mr. Hartwell. David takes another deep breath, visibly trying to calm himself. I'm sorry. I shouldn't yell. But Dr. Webb, you need to understand something. I have anxiety disorder. Bad anxiety. Ellen knows that. When I get stressed, I spiral. She's seen it happen, and I get why she was scared to tell me this. I get it. But I'm not a child. I'm not fragile. I need to know what's happening to my own body. You absolutely have that right, Dr. Webb confirms. Okay, so tell me everything. No holding back, no softening it. What does the scan actually show? I pull up the CT images on the computer in the examination room. This is your pancreas here. I point to the relevant anatomy on the screen. And this is the mass. You can see it's irregular in shape. It's encasing this blood vessel here, and it's compressing your bile duct, which is probably causing some of the pain you've been experiencing. David studies the images with surprising calm. And these spots here? He points to the liver lesions. We're concerned those might be metastases, places where cancer cells may have spread, but again, we need a biopsy to confirm. How long have I had this? Could we have caught it earlier? It's the question patients always ask, searching for the moment when intervention might have changed the outcome. Pancreatic cancer typically doesn't cause symptoms until it's already advanced. Your previous labs and checkups were normal. There's no indication this could have been detected earlier. David nods, still looking at the screen. Then he turns to Ellen. When Jim got diagnosed with colon cancer, I told you I never wanted to go through that. Do you remember? I remember, Ellen says quietly. I watched him suffer through chemotherapy. I saw what it did to him, the vomiting, the weakness, the loss of dignity, and I said I'd rather die than go through that. He pauses. I meant it then, but that was watching someone else's suffering. This is different. This is my life. So what are you saying? Ellen asks. I'm saying I don't know yet. I need more information. I need to talk to oncologists, understand what treatment actually looks like, what the odds are. But I need to make that decision myself, Ellen. Not have it made for me by you deciding to hide information or by doctors pushing treatments I don't want. Dr. Webb nods approvingly. That's exactly the right approach, Mr. Hartwell. Gather information, ask questions, take time to think. This isn't a decision that needs to be made today. What happens next? David asks. What's the timeline? We'll schedule a biopsy, probably within the next few days. Once we have definitive diagnosis, we'll connect you with oncology for a consultation. They'll discuss treatment options, side effects, expected outcomes. You can ask as many questions as you need, and then you make decisions based on what feels right for you. And if I decide I don't want treatment, the question hangs in the air, heavy with implication. Then we transition to palliative care, I say. Focus on keeping you comfortable, managing symptoms, maximizing quality of life for whatever time you have. That's also a valid choice. David looks at Ellen. Would you be okay with that? If I chose not to treat? She's crying now, tears streaming down her face. No, I'd want to fight for every possible day with you. But David, it's your life, your body, your choice. And whatever you decide, I'll support you. I promise. Even if you disagree with my decision, even then, there's a moment of connection between them. A wordless communication built on decades of shared life. Then David turns back to us. Schedule the biopsy. I need to know for certain what we're dealing with, and I want to talk to oncology. I'm not committing to anything, but I want information. We'll arrange both, Dr. Webb confirms. And Mr. Hartwell, I'm going to recommend that we also involve our psychiatry team. Not because you're handling this poorly, you're actually handling it remarkably well, but because having additional support for managing the anxiety through this process could be helpful. David considers this. That's probably smart. Yes, okay. Dr. Webb stands. We'll admit you for observation tonight. Get some of the pain under better control. Doctor. Reyes will coordinate with interventional radiology for the biopsy, probably tomorrow or the next day, and we'll make sure you have all the support and information you need. Thank you, David says. Then, looking at me specifically, Dr. Reyes, thank you for telling me the truth. I know Ellen probably asked you not to. I glance at Ellen, who's looking down at her hands. Your wife was trying to protect you from information she was afraid would hurt you. Her intentions came from love. I know they did, David says softly. But love without trust is just control with better packaging. The biopsy is scheduled for the following morning at 8 a.m. I spend the evening reviewing David's case, reading literature about pancreatic cancer, and thinking about the conversation we'd had, about Ellen's desperate attempt to protect her husband by hiding information, about David's insistence on honesty even when the truth was devastating, about the tension between protection and autonomy. Around 9 p.m., I get a page from the nurse on the floor where David has been admitted. When I call back, she sounds concerned. Dr. Reyes, Mr. Hartwell is requesting to speak with you. He seems agitated. I head up to the 5th floor and find David sitting in a chair by the window of his hospital room, looking out at the city lights. Ellen isn't there. Visiting hours are over, and she's gone home for the night. Mr. Hartwell? The nurse said you wanted to talk? He turns to look at me, and I'm struck by how much he seems to have aged in the 6 hours since our conversation. I owe Ellen an apology, he says without preamble. I was too harsh with her today. I pull up a chair. She was trying to protect you. I know, and I snapped at her for it. But Dr. Reyes, here's what I've been thinking about. Ellen was wrong to try to hide the diagnosis from me. We agree on that, right? Yes, but she wasn't entirely wrong about what she was afraid of. He gestures vaguely at himself. This, what I'm feeling right now, this is exactly what she was trying to prevent. Since you left this afternoon, I've been spiraling. I can't stop thinking about dying, about pain, about losing time with my family, about everything I'll never get to do. My anxiety medication isn't touching it. That's completely understandable, Mr. Hartwell. You received devastating news today. But here's the thing. If Ellen had successfully hidden the diagnosis from me, I wouldn't be feeling this right now. I'd be home, ignorant, probably in some pain, but not panicking about mortality. So in a utilitarian sense, her plan would have reduced my suffering. I see where he's going with this, and it's an ethical territory I'm not entirely comfortable navigating. Short term, perhaps, but eventually I'd get sicker. Eventually, the truth would come out. I know. He runs a hand through his thinning hair. I'm not saying she was right. I'm saying I understand why she thought she was right. There's a difference. What made you change your mind? This afternoon, you were angry about her trying to hide information from you. I was. I am. But after she left tonight, I started thinking about something she said 2 years ago when Jim was dying. She told me that loving someone means bearing witness to their suffering. She said sometimes the hardest part of love is watching someone you love be in pain and not being able to fix it. He pauses, collecting his thoughts. Today, she was trying to fix it. She was trying to spare me pain by hiding information. It was wrong, but it came from that same place, from not being able to bear watching me suffer, and I yelled at her for it. Mr. Hartwell, your anger was justified. You have a right to information about your own body. Rights. He says the word thoughtfully. Medical ethics is built on rights, isn't it? Patient autonomy, informed consent, the right to know. But what about responsibilities? Don't I have a responsibility to the people who love me to not make their lives harder than they need to be? This is veering into philosophical territory that residency hasn't fully prepared me for. I'm not sure I follow. If I choose aggressive treatment, chemotherapy, surgery, radiation, I'll be sick, weak. Ellen will have to take care of me, watch me suffer. Our kids will have to deal with medical bills, hospital visits, the slow decline. Is it selfish to put them through that for maybe a few extra months of life? Those are questions only you can answer, Mr. Hartwell. But I think you're getting ahead of yourself. We don't have a confirmed diagnosis yet. We don't know staging or treatment options. You're catastrophizing based on incomplete information. My therapist would say the same thing, he acknowledges. But here's what I do know. I'm 68 years old. I've had a good life. My kids are grown. Ellen and I have had 42 years together, more than a lot of people get. If this is cancer, if the prognosis is as bad as the statistics suggest, maybe the most loving thing I can do is choose not to fight. Let it take me quickly rather than dragging it out. That's one perspective. But Mr. Hartwell, depression and anxiety can make everything look hopeless. Before you make any major decisions, let's get you connected with psychiatry. Let's make sure your thinking isn't being distorted by the acute stress of the diagnosis. He smiles sadly. You're a good doctor, Dr. Reyes. You actually listen. But I'm not depressed. I'm being realistic. There's a difference. Before I can respond, his phone buzzes on the bedside table. He picks it up, reads something, and his expression shifts. It's Ellen, he says. She's asking if I'm okay. If I need her to come back. Do you? He types a response, then shows it to me. I'm okay. Please rest. I love you and I'm sorry I was harsh today. You were trying to protect me and I appreciate that even though I disagree with the method. A moment later, her response comes back. I love you too. I'm sorry I tried to make decisions for you. Tomorrow we face this together. David smiles at the message, and some of the tension leaves his face. 42 years and we're still figuring out how to navigate hard things together. That's a testament to your relationship, or evidence that marriage is a perpetual work in progress. He sets the phone down. Dr. Reyes, can I ask you something? If you were me, 68, facing probable pancreatic cancer, what would you do? It's a question residents get asked sometimes, and there's no good answer. I honestly don't know, Mr. Hartwell. I'm 27 and healthy. I can't imagine being in your position. Fair enough. Different question then. If it was your father facing this, what would you want him to do? That hits differently. I think about my own father, roughly the same age as David, worn down by years of physical labor but still present in my life. Still someone I call when I need advice. I'd want him to get all the information first. I say carefully. Talk to oncology. Understand the actual treatment plan, not the worst-case scenario. Find out if there are clinical trials or newer therapies, and then I'd want him to make whatever choice felt right to him, and I'd support it. Even if it meant choosing not to treat, even then, because ultimately, it's his life and his death. And forcing treatment on someone who doesn't want it is just as wrong as denying treatment to someone who does. David nods slowly. That's what I needed to hear. Thank you. I stay with him for another 20 minutes, just talking about his career as an accountant, his kids and grandchildren, his hobbies, his life beyond this diagnosis. By the time I leave, he seems calmer, more settled. In the hallway outside his room, I pull out my phone and text Dr. Webb. Had a long conversation with Mr. Hartwell tonight. He's processing. Will need strong psych support, but he's thoughtful and insightful about his situation. Dr. Webb's response comes quickly. Good work. This case is going to challenge a lot of your assumptions about patient autonomy and family dynamics. Pay attention to what you're learning. The biopsy the next morning confirms what we already knew: adenocarcinoma of the pancreas. Stage 4, with metastases to the liver. Unresectable due to vascular involvement. I'm the one who tells David and Ellen, both of them sitting together on the hospital bed, holding hands. It's cancer, I say directly, remembering David's request for straightforward communication. Pancreatic adenocarcinoma, stage 4. The tumor has grown into major blood vessels, which means surgery to remove it isn't an option. And there are metastases in your liver, which confirms the cancer has spread. Ellen's face crumples. David's expression is harder to read. Sadness, but also a strange sort of calm, as if the definitive diagnosis has removed uncertainty and replaced it with clarity. What's the timeline? David asks. Without treatment, how long? That's difficult to predict with certainty. Months, probably. The oncology team can give you more specific information based on the tumor characteristics and your overall health. And with treatment? The oncology team will discuss that with you. But Mr. Hartwell, I want to be clear. Treatment for stage 4 pancreatic cancer is palliative, not curative. The goal would be to extend life and maintain quality, not to cure the disease. Extend life by how much? I choose my words carefully. Studies show chemotherapy can extend median survival by a few months compared to no treatment, but the quality of that time varies significantly. Some patients tolerate treatment well, others find the side effects significantly impact their quality of life. David is quiet for a long moment. Then he looks at Ellen. What do you think? I think I want every possible day with you, she says, her voice thick with tears. But I also want those days to be good days, not days where you're miserable from treatment. So I think you need to decide what matters most to you. What if I can't decide? What if both options feel equally terrible? Then we make the decision together, Ellen says firmly. But David, I need you to promise me something. Whatever you decide, I need to know it's really your choice. Not what you think I want. Not what you think is less burdensome for the family. Your actual, honest choice. How can I separate my choice from what I think is best for everyone else? Maybe you can't, I interject. Maybe those considerations are inherently part of how you make decisions. But Mrs. Hartwell is right. The decision needs to come from you, informed by your values and priorities. The oncology consultation happens that afternoon. Dr. Patricia Chen, a medical oncologist with 20 years of experience, spends 90 minutes with David and Ellen. She explains treatment options, a chemotherapy regimen called FOLFIRINOX that's aggressive and has significant side effects, or a gentler single-agent chemotherapy that's easier to tolerate but less effective. She discusses expected outcomes, survival curves, quality of life considerations. She's honest without being cruel, hopeful without being unrealistic. At the end of the consultation, Dr. Chen asks David if he has any questions. Just one, he says. If I choose not to treat, what happens? What does dying from pancreatic cancer look like? Dr. Chen doesn't flinch from the question. Initially, you'd likely feel increasing fatigue and abdominal discomfort. As the tumor grows, you might develop jaundice, more significant pain that would require medication management. Eventually, the cancer would affect liver function and other organs. We'd involve palliative care to manage symptoms and keep you comfortable. With good symptom management, many patients have peaceful deaths surrounded by family. How long from decision to death? It varies. Without treatment, probably 3 to 6 months, though it could be shorter or longer. With palliative care support, we can ensure that time is as comfortable as possible. David takes Ellen's hand. Can we have some time to think about this? Of course, Dr. Chen says. There's no rush. Take whatever time you need. David and Ellen go home 3 days later. No decision made yet about treatment. Dr. Chen has given them information packets, phone numbers, resources. They have an appointment scheduled in 1 week to discuss their decision. I don't expect to see them again. They'll be under oncology's care now, no longer on my service. But 2 weeks later, I get a message that David Hartwell is requesting to speak with me. I find them in the oncology clinic waiting room. David looks thinner than he did 2 weeks ago, but his eyes are clear and calm. Dr. Reyes, he says, standing to shake my hand. Thank you for making time to see us. Of course. How are you doing? I've made a decision, he says. I wanted to tell you personally since you were the first doctor who was honest with me about what we were dealing with. We moved to a private consultation room. Once we're seated, David continues. I've decided not to pursue chemotherapy. I'm going to do palliative care only, manage symptoms, stay comfortable, and spend whatever time I have left with family. Can I ask what led to that decision? Several things. First, Dr. Chen was honest about the statistics. Best case scenario with treatment, maybe 6 to 8 months instead of 3 to 6 without treatment. That's not a lot of extra time, and it would come at the cost of being sick from chemo. He pauses, gathering his thoughts. But more importantly, I thought about what matters most to me, and it's not living as long as possible. It's living as well as possible with the time I have. I want to take my grandchildren to the park. I want to have Sunday dinners with my kids. I want to travel a bit with Ellen to places we've always talked about visiting. I don't want to spend those months vomiting from chemo and being too weak to enjoy life. Ellen squeezes his hand. I fought this decision at first. I wanted him to try treatment, to fight for every possible day. But he's right. Quality matters more than quantity. Plus, David adds with a slight smile, Ellen made me promise that I'd pursue treatment if that's what I genuinely wanted. She said she'd support me either way, and I believe her. So I know this decision isn't coming from pressure or guilt. It's genuinely what feels right to me. I think that's a very thoughtful decision, Mr. Hartwell, and I'm glad you found a choice that aligns with your values. There's something else I wanted to tell you, David says. Remember when Ellen tried to hide my diagnosis? I was angry about it at the time, but I've been thinking about it a lot, and I understand now why she did it. Why do you think she did it? Because she knew me well enough to predict how I'd respond. She knew I'd spiral with anxiety. She knew I'd spend weeks agonizing over decisions. She knew this diagnosis would consume me, and she loved me enough to want to protect me from that suffering. He looks at Ellen with obvious affection. She was wrong to try to hide it. We both agree on that. I had a right to know. But her instinct to protect me, that wasn't control. That was love. Sometimes the people who love us most can see our vulnerabilities more clearly than we can see them ourselves. And sometimes they make choices, even wrong choices, out of desperate desire to shield us from pain. That's a generous interpretation, I observe. It's the true interpretation. Ellen has spent 42 years supporting me through anxiety, through difficult times, through moments when I couldn't support myself. She's earned the benefit of the doubt. And I want her to know, he turns to look directly at his wife, that even though I disagreed with what you tried to do, I understand why you tried to do it. And I love you for caring that much. Ellen is crying quietly. I'm sorry I tried to make decisions for you. And I'm sorry I yelled at you about it. We're both doing our best in an impossible situation. I feel like I'm witnessing something deeply private, something sacred. This is marriage at its most raw and real. Two people navigating crisis, making mistakes, offering forgiveness, choosing each other even when it's hard. Dr. Reyes, David says, turning back to me, I wanted to tell you all this because I think it's important for young doctors to understand something. Medical ethics talks about patient autonomy like it's simple. Patients have the right to make their own decisions, but it's not simple. We exist in relationships. We make decisions that affect other people. We're influenced by the people who love us, and that's not always a bad thing. What are you saying? I'm saying that Ellen trying to protect me wasn't a violation of my autonomy. It was an expression of our relationship. Yes, ultimately I needed to be the one to make decisions about my care. But her input, her concerns, her desire to protect me, those are legitimate parts of the decision-making process. Maybe medical ethics needs more room for understanding that we're not isolated individuals making choices in a vacuum. We're people embedded in relationships, and those relationships matter. It's the most sophisticated articulation of relational autonomy I've ever heard from a patient. That's a really important insight, Mr. Hartwell. Well, I've had a lot of time to think lately. He stands, extending his hand again. Thank you for being honest with me from the beginning. Thank you for treating me like an adult who could handle difficult information. And thank you for understanding that Ellen was trying to do right by me, even when her method was wrong. I shake his hand. Thank you for sharing your perspective. It's helped me think about these issues more deeply. As they're leaving, Ellen turns back. Dr. Reyes, can I say something? Of course. When you insisted on telling David about the diagnosis, I was angry. I thought you were being rigid, following rules without considering the human cost. But you were right. David needed to know. He needed to make his own choices. And now, facing the end of his life, he has the power to decide how he wants to spend his remaining time. That's a gift, even if it came wrapped in terrible news. She pauses. So, thank you for being the kind of doctor who respects patients enough to tell them hard truths, even when people like me are begging you not to.
David Hartwell died 4 months later, at home, surrounded by family. I learned about it from an obituary in the local paper that Dr. Webb showed me during morning rounds. The obituary was beautiful, not sad or maudlin, but celebratory. It described David's life, his career, his family, his passions. It mentioned that he died peacefully at home after a brief illness, and that in lieu of flowers, the family requested donations to the Anxiety and Depression Association of America.
2 weeks after the obituary ran, I received a letter at the hospital. The return address was Ellen Hartwells. Dear Dr. Reyes, I'm writing to tell you about David's final months because I think you earned the right to know how the story ended. After we decided on palliative care only, David did exactly what he said he wanted to do. We took our grandchildren to the zoo, the aquarium, the park. We had Sunday dinners with our kids every single week. We traveled to the Grand Canyon, which David had always wanted to see. We spent quiet evenings at home just being together. He had good days and bad days. The pain got worse as time went on, but the palliative care team was excellent at managing it. He was never in agony. He was never suffering beyond what medication could control. He remained himself until very close to the end, joking with the grandkids, giving advice to our son, telling me stories about our early years together. 3 days before he died, he told me he had no regrets about his decision. He said the 4 months of quality time with family were worth more than 6 months of being sick from chemotherapy. He said he was grateful he got to leave on his own terms, with dignity intact. The night he died, all of us were there. Me, our children, our grandchildren. We held his hands and told him we loved him. He died peacefully, without fear, surrounded by the people who mattered most to him. I'm telling you this because I want you to know that respecting his autonomy, insisting that he be told the truth so he could make his own decisions, gave him those 4 months. If I'd succeeded in hiding the diagnosis, if he'd never known until he got too sick to hide it anymore, he wouldn't have had time to plan, to choose, to live intentionally in his final months. You were right, Dr. Reyes. I was wrong, and I'm grateful you had the courage to tell him the truth even when I was begging you not to. I also want to thank you for understanding why I tried to hide it. David and I talked about that a lot in his final months. He helped me see that loving someone doesn't mean protecting them from all pain. Sometimes it means standing beside them while they face pain, rather than trying to shield them from reality. I've learned so much from this experience. About love, about autonomy, about the difference between protection and control. I hope you learned something too. With deep gratitude, Ellen Hartwell. I read the letter 3 times, then saved it in a folder where I kept meaningful correspondence from patients and families. That night, I pulled out my journal and wrote about David and Ellen, about the ethical dilemma we'd navigated together, about what I'd learned. Today, I learned that patient autonomy isn't just about rights. It's about respect. Respect for people's capacity to make their own decisions, even difficult decisions, even decisions others disagree with. Ellen tried to hide David's diagnosis because she loved him and wanted to protect him from suffering. Her intentions were good, but good intentions don't override fundamental ethical principles. David had the right to know about his own body, his own illness, his own mortality. Not because that knowledge would make him happy, it didn't, but because respecting his personhood meant treating him as capable of handling difficult information and making his own choices. But I also learned that autonomy exists in relationship. David didn't make his decision in isolation. He considered Ellen's needs, his children's feelings, his values about quality versus quantity of life. And ultimately, his decision not to pursue aggressive treatment was as much about who he was in relationship to others as it was about his individual preferences. Ellen taught me that families sometimes make decisions from fear disguised as love. That desperation to protect someone can lead to choices that actually undermine their dignity and agency. But she also taught me that those choices come from real love, real caring, real inability to bear watching someone suffer. And David taught me that respecting autonomy means creating space for people to make decisions that align with their values, even when those values include consideration of how their choices affect others. Dr. Webb says medicine is full of ethical gray spaces where the right answer isn't clear. This case proved him right. There were legitimate concerns on all sides. Ellen's fear that disclosure would devastate David, David's right to information about his own body, the question of how much protection is appropriate, and how much becomes controlling. But in the end, truth won out. And that truth gave David the power to choose how he wanted to spend his final months. That's what autonomy means. Not just the right to know, but the right to decide based on that knowledge. I'll carry this case with me for the rest of my career. 6 months after David's death, during a medical ethics lecture for residents, the instructor presented a case study. A family wants to hide a cancer diagnosis from a patient to protect them from emotional distress. How should the medical team respond? Most residents immediately said the patient must be told. It's their right. It's the law. It's ethically required. But I raised my hand and told David and Ellen's story about the wife who tried to hide the diagnosis from love and fear, about the husband who insisted on knowing the truth, but also understood why his wife tried to protect him, about how respecting autonomy doesn't mean ignoring the relational context in which decisions are made. So what's the answer? Another resident asked. Should the doctors have told the patient or not? They should have told him, I said, but they should have done it with compassion and understanding for why the wife was scared. And they should have recognized that the wife's concerns, while not justifying withholding information, were coming from a place of legitimate care and were worth addressing. The ethics instructor nodded. That's exactly right. Medical ethics isn't about rigid rules applied without consideration of context. It's about principles like autonomy, beneficence, non-maleficence that sometimes exist in tension with each other. Our job is to navigate those tensions thoughtfully. After the lecture, Dr. Webb approached me. You handled that case well, Noah. Both the clinical management and the ethical complexity. I made mistakes, I admitted. I was frustrated with Mrs. Hartwell at first. I saw her as an obstacle rather than understanding her perspective. But you learned. That's what matters. And you gave that patient the gift of informed choice in his final months. That's not a small thing. Do you think I was right to insist on telling him? Sometimes I wonder if Mrs. Hartwell's instinct was correct, if he would have been happier not knowing. Would he have been happier? Maybe, in the very short term. But would he have been more autonomous, more respected as a person? Would he have had the opportunity to make meaningful choices about his final months? No. And those things matter just as much as happiness. Dr. Webb paused. Here's what I want you to remember, Noah. We're not in the business of making people happy. We're in the business of caring for them, respecting them, and providing them with the information and support they need to live according to their own values. Sometimes that means delivering news that makes people unhappy, but unhappiness isn't the same as harm. Sometimes truth, even painful truth, is the most respectful thing we can offer. 1 year after David's death, I received another letter from Ellen. This one was shorter. Dear Dr. Reyes, I'm writing to tell you that I've started volunteering with a cancer support organization working specifically with families who are navigating end-of-life decisions. I share David's story, including my mistake of trying to hide his diagnosis, and I talk about what I learned. So many families are struggling with the same impulse I had, to protect their loved ones from painful information. I help them understand that protection and respect aren't the same thing, and that giving someone the truth gives them the power to make their own choices. In a strange way, David's death gave me a purpose. I'm helping other families avoid the mistake I almost made. And I'm telling everyone who'll listen about the young doctor who had the courage to insist on truth, even when a scared wife was begging him not to. Thank you for that courage. It changed how David died, and it changed how I live. Ellen, I kept that letter too. And sometimes when I face difficult ethical decisions, when families ask me to withhold information, when patients make choices I disagree with, when the right answer isn't clear, I think about David and Ellen Hartwell. I think about the report Ellen tried to hide in her purse, about David's insistence on truth even when truth was devastating, about 4 months of intentional living made possible by knowledge and choice, about love that learned to trust rather than control. And I remember that medicine isn't just about treating disease. It's about respecting people's fundamental right to know about their own bodies, to make their own decisions, to die in ways that align with their values. Even when, especially when, that truth is hard to hear. That's what David and Ellen taught me. And I'll carry those lessons through every difficult conversation, every ethical dilemma, every moment when someone's life and death hang in the balance. Because sometimes the most caring thing we can do is tell the truth and trust people to handle it, even when the truth is terrible, even when love wants to hide it, even when protecting seems kinder than respecting. The truth matters. Autonomy matters. And people deserve the dignity of making their own choices about their own lives and deaths. That's what it means to be a doctor. That's what David and Ellen Hartwell taught me, and I'll never forget.